Good evening, everyone, and welcome to the webinar. We're so excited that you're here, and we're so excited to have Dr. Jessica Reub with Southern Urogynecology here tonight to share important educational information about bladder and bowel health. My name is Stacy Carr. I'm with the Axonics Therapy team, which is now part of Boston Scientific, and I'll be your moderator this evening. Just a few quick notes before we begin. Your camera and microphone have been disabled, so we can't see or hear you. If you have any questions during the webinar, please feel free to type them in the Q&A feature located at the bottom of your screen, and I'll direct these questions to Dr. Reub at the end of the presentation during the question and answer session. Please note that all questions will remain anonymous, and we're only able to answer general questions and not able to utilize the setting to diagnose your specific condition. Before the presentation begins, you'll see important safety information about the products. As with any medical procedure, there are some risks, and we encourage you to take all of those important safety-related questions with you to your healthcare provider appointment. And you can also visit the Axonics website or the Boston Scientific website for additional safety information. So once again, I want to welcome everyone to the webinar. We're so excited to have you here. We're excited that Dr. Reub is here with Southern Urogynecology, and she's going to share important information about bladder dysfunction, the common symptoms that patients experience, and the treatment options that may help you regain control. So without further ado, I'd like to introduce Dr. Reub.
Thank you so much. I am so psyched to be here tonight, everybody. We've had a record turnout of people interested in bladder health, so I think word's getting out how important this is, and I'm really excited that we have so many people who really wanting to, take control of their bladder and their pelvic health. So I'm going to give you guys a lot of information, and some patients, if you've seen me before, this is going to be a little bit of a review, but it never hurts to review because so many of us kind of ignore things for so long. As many of us know, bladder and bowel symptoms can be so disruptive for our lives, and I hate that women just get in this habit of, okay, I'm just going to find every bathroom and see it, stop at every bathroom I see. I'm going to plan to take breaks, and I know I might pay all this money to go to this event, but I'm going to make sure that I'm close to a bathroom just in case. This bladder mapping is something we've gotten. The bathroom mapping is something we've gotten used to, but that doesn't mean it's a really good solution. We're just kind of putting a Band-Aid on the problem and accepting that this is part of our life. And I think it's important to know that it's not a normal part of just getting older or being a woman, and it's not your fault. It's not something that you did. That you don't have to live this way. And importantly, it's going to affect your quality of life when we ignore it. And I hate to see that. Some of the obvious ones is people just stop running or they stop doing, real high impact activities because they are worried about leaking. And the simple things is like wearing our black leggings just doesn't cut it at some point, and so you just stop going. The social interactions of trying to make sure you're not going someplace that you don't know where the bathroom is, or modifying your travel plans. And obviously with work too, if you can't have frequent bathroom breaks, it's going to affect your life. And I hate that for women, that so many of us just accept that I'll just wear a pad, and that's a good answer, like pads and these incontinence underwears. Although I'm glad that the field is developing new things for women, I hate to see that as our answer, because it's not a real answer. It's just really putting it's just really kind of putting a Band-Aid on what's happening. The key here is to know that you're not alone with this incontinence, that this isn't this should be something we talk about. And that's why I like to give these webinars, just to let people know that this is something that we need to talk about and address head on. And you don't have to live like this. There are 30 million women out there that have stress incontinence, for example, and that is a huge number of women that are affected. And nowadays there are simple answers that you really just don't have to just accept that that's the case. Stress incontinence in particular affects 1 in 3 women at some point in our lives. It is it's a condition that is due to a loss of support along the urethra. And so stress incontinence is that leakage when we cough, sneeze, laugh, jump up and down with our kids on the trampoline, and suddenly we are losing some pee. It's about increasing that pressure abdominally on top of the bladder, and the muscles around the urethra, the sphincter muscle, the ligaments holding the urethra up, and your pelvic floor muscles are no longer strong enough that they're keeping that pee in when they get that challenge of that pressure on the bladder. Um, and it is absolutely a cause of what our pelvis has been through. For many of us, that's childbirth was a big one. That's the most traumatic thing our pelvises ever go through, and it can weaken the ligament support around the urethra. Certainly just all our life experience. So it's not just the childbirth, it's also our weight changes, coughing, smoking weakens that ligament and muscle support, and our habits. If we're doing a lot of heavy lifting, that's going to challenge your pelvis more. So, and it's not that I want you to stop those things. I want you to be able to be physically active, and being physically active is very important for our bone density and our bone health. So weight bearing exercise is very important for that. And in order to keep your activity level where you want it, there are treatments available for us to get you there. So when it comes to stress incontinence, the it should really be like the other way around, because the base of therapy is our pelvic floor strength. A lot of us we talk about Kegels when we're after we've had babies, and that's when we're really thinking about it, as we're like nursing our kids and we're like, okay, we should probably work on these Kegels. But really, Kegels are a lifelong exercise that we all need to keep up with, and let's just admit that we could all do a better job. So the pelvic floor is that hammock or that basket of muscles at the base of your pelvis. And those muscles wrap around the urethra, they wrap around the vagina, and they wrap around the rectum. The pelvic floor exercise is when you squeeze that muscle and you can feel your rectum and your vagina and your urethra lift up. Without using your butt muscles or your thigh muscles, it's just the internal muscles. So that is sometimes hard for people, to just isolate those internal muscles. And thank goodness nowadays we have a lot of resources available for that. So to strengthen your pelvic floor, what we should be aiming for is that all of us should get in the habit of being able to do 3 sets of 10 squeezes every day. And we're trying to get to the point where we can hold that squeeze for 10 seconds strongly. That's the landmark of a good, strong pelvic floor. When we do core exercises like here we're picturing a glute bridge. When you're doing glute bridges, you're squeezing that core and you're squeezing that pelvic floor. In fact, there's some things that are called a core to floor exercises. So a lot of the yoga moves, Pilates, many of those things, you're actually engaging your pelvic floor too. So you may be doing better than you think you are. But in the long term, we really need a good pelvic floor tone our entire lives. So if you're having trouble with identifying your pelvic floor, you feel like and some people say, oh, how about if I stop my pee? Well, yes, that is the right muscle if you're stopping your pee stream, but I do not want you stopping your pee stream to practice your Kegel exercises. Why? Because that creates a different problem, which is called dysfunctional voiding, when you're trying to empty your bladder, and actually those pelvic muscles need to relax and open for you to let the pee out. And so if you're trying to squeeze them as you're peeing, you're actually like closing the door on your bladder. And that's not a good habit to get into. So although I like the idea of being able to recognize, like, I squeeze the right muscle, you can also do that with me. I can tell you, you squeeze the right muscle, but I don't want you doing it regularly while you're urinating. Beyond just working on it on your own, there are pelvic floor therapists, many available. Thank goodness. It's becoming a hot topic for women's pelvic health, and there's so many more pelvic floor physical therapists than there even were 5 years ago. So there are resources for you, and there's in-person physical therapy. There is virtual physical therapy that comes with a vaginal insert for you to squeeze upon 5 minutes a day. Then you meet with your virtual physical therapist once a week, and they can help assess and make sure you're making improvements. There are online things you can purchase on your own, like the PeriFit or the LV pelvic trainer. Those come with a vaginal insert that then has an app on your phone, and they try to make it fun. They make it so the PeriFit, for example, has a little butterfly that goes across the screen and grabs the coins, and that's you making sure that you did a good job with your pelvic floor squeezes. So lots of resources nowadays. And really, it's whatever resource helps you actually commit to strengthening that pelvic floor muscle. That's what you should use. Whatever you're comfortable with and helps you commit to actually strengthening the muscles, because consistency is everything when you're trying to increase that strength. And the lifestyle things with stress incontinence, it's really the things we all naturally do, pee before you exercise. All of us are trying to be at our healthiest weight. And I think if you are smoking is a big one. You want to try to let that go in your life, because for lots of reasons, but your leaking is one of them. So other than that, it starts with pelvic floor strength. So what else can we do? So when it comes to interventions, when you come to my office, I'm going to go through all this with you, and we're going to assess your pelvic floor muscles, and we're going to try to quantify how much is this bothering you, and what steps do you want to take to get more comfortable. I do have to actually help you demonstrate the leakage in order to make sure that we're doing the right thing, that we're treating you the right thing. And then we can offer therapies. And the two main therapies that people have heard of is the sling, and the other one is the urethral bulking. So sling is still our gold standard of care by all societies. It's a mesh. It's a hammock of mesh that's underneath the urethra, as pictured here. And it helps support that urethra so that when you cough, laugh, and sneeze, that urethra has a backboard to sit upon. And so it doesn't fill with urine as easily. This is the most well-studied incontinence procedure that we have on the market. And that's because it's been around for so long. This is not a mesh that's ever been removed from the market. It's kind of separated from the mesh that was removed for other reasons. And really that was about unintentional injuries and placing mesh where it shouldn't go. This is a very reliable treatment for stress incontinence. And it's 90% of women that are happy that they did it, and they are totally dry. What is the downsides? It is an outpatient surgery, and I do need you to take 6 weeks off, from up to 6 weeks from heavy lifting, aerobic activity, and let everything heal. And I'm very conservative about that, but I do want you to have a good result and be totally healed before you're challenging that again. The other risks are mesh-related risks, such as mesh erosion. That mesh is with you for the long term, and the concern we have is erosion into the vaginal wall, urethra or bladder injury during the procedure, and then voiding dysfunction or feeling like that sling is too much for you. So there are several things we do to try to mitigate that risk, but this is an intervention that it can be done in an outpatient procedure, like 30-minute procedure, going home the same day. But you do have to do some restrictions for me. So you just got to find a good time in your life that is possible. Very reliable. Some women just aren't ready for that kind of intervention. They want something that's less invasive. So this is where urethral bulking has come into play. Urethral bulking, this is not a new treatment. It's a new agent that we're using. Years ago, we used different types of bulking agents, and they would degrade pretty quickly so that people were in the same place they started at 2 years later. And for a lot of people, that's not really worth it. Nowadays, we have this new agent called Bulkamid, and it is a hydrogel-based filler that we place into the lining of the urethra at that proximal urethral area to help support the urethra and build up the wall so that you can have that seal of the urethra, keeping that pee in. What I really like about this is that it is a very benign substance. I have not seen reactions to this. It's a water-based treatment that's 97% water and a polymer that keeps it together. It stays where we put it. And what women really appreciate is that it is an outpatient procedure, either done in a surgery center or in the office, and you can go back to your normal activity the next day. There are not restrictions on this. I tell you to take it easy that day, but beyond that, there's not restrictions. And I think people really appreciate that part of it. This has been a procedure or treatment that we have utilized so much it's actually reduced how many people are going for slings. And I love that. Whatever makes you more comfortable and is something that feels like that can support you without feeling scary to you. And it's the most minimally invasive procedure. I have a little video on it. If I can get to play.
Bulkamid can help provide the relief you've been longing for. The short, incision-free procedure typically takes less than 10 minutes. Involves 3 to 4 small injections of soft, water-based gel into the wall of the urethra to help prevent urine from leaking out of the bladder during day-to-day activities. It's safe, quick, and most patients can get back to your normal activities almost immediately.
So this is really what's going to help restore your urethral coaptation, which is it closing and sealing from preventing urine from escaping. I think it's I call it my lip filler of the urethra. And since people are more like accepting of the idea of filler, I think that it's become more accepted as well. And I think it's been a really helpful procedure. Now, when you compare it to the sling rate, is there one that's better? Well, the bulking is a gentler procedure. And so the satisfaction rate is in 80 percentile of women saying that I'm happy I did it. I feel much better. 60% being totally, totally dry. So is it possible that you can have some breakthrough leakage with the bulking? Yes. And is the dry rate higher than the sling? Yes. But the satisfaction rate is high with both procedures. And if this feels like something that is less invasive and you feel more comfortable with, it's absolutely a great option. And the other thing I want to remind people is that this is not you're not burning a bridge. So if you decide, well, let me try the less invasive one first, and then if I don't feel like it got me dry enough, then I'll maybe tackle the sling and make sure I stop my running for 6 weeks and whatnot. I think that's a perfectly reasonable way to go about it. You're not burning a bridge. You're supporting the urethra in 2 different ways: internally in the urethral tube and externally from that ligament support. And the Kegels as well, I'm going to tell you to keep at it because it's lifelong pelvic floor health. Okay. So this is a simple procedure. 92% of women report being improved or cured. I usually have people in my office for about an hour, and that's because the majority of that time is taken to make sure your urethra is nice and numb and you're as comfortable and numb as I can get you. And then we do the procedure, which I mean, in my hands is less than 5 minutes, really. The long-lasting relief. So unlike its predecessors, this has been studied for up to 7 years, and more than 60% of women at 7 years said they could still feel the effects of the Bulkamid. So that's a huge difference from what we had before. And I think that's why this is getting so heavily utilized compared to the past agents. So it's really become one of my favorites. And I do it very frequently. I've been very happy with results. So let's switch gears now to our other types of incontinence, and that is called our urge incontinence. So, overactive bladder affects 50 million people in the United States. And in addition to overactive bladder, we're going to talk about fecal incontinence at the same time, because as it turns out, the nerves are shared between the bladder and your bowels, your rectum. So oftentimes these two organs mirror each other, or you can be suffering from both. So the fecal incontinence is actually treated very similar to overactive bladder. So we'll go through that. Fecal incontinence is one of mine that is the hardest to get people to talk about, and I totally understand why. It's very embarrassing to go through, and just very isolating and hard on your social life, I think, more than anything. And for that reason, I'm so happy to be able to talk about this on these kind of platforms, because so many women just keep it as their little secret and they don't tell anybody about it. And I'm really glad when people bring it up to me and say, this is happening sometimes, and we can actually try to tackle it head on and find a solution. So the conditions that are treated by nerve therapies, we're going to talk about all as a group, and that's overactive bladder, the sudden urge to urinate. I better get there quick or I'm about to pee on the way to the toilet. That is an overactive bladder. Those patients that are saying, I can get to my door or I pull into my garage and suddenly I'm about to pee my pants. That's an overactive bladder. The bladder is jumping the gun. It knows that you're close to your bathroom and it's like, cool, close enough. We're going to pee right now. There is the running water. That's another very obvious trigger that is all about the overactive bladder. It just stimulates the bladder enough to say, okay, now it's time. The fecal incontinence can be with the same event. It can be a fecal urgency. When you got to go, you better get there quick. And that can cause a loss of stool. Sometimes fecal incontinence is more passive, meaning you didn't know it was happening. You didn't have any sensation, and some stool is leaking out. Both of those can happen. And then urinary retention, so not emptying the bladder completely. That is often something that we don't know is happening until it gets complicated, like you're starting to get bladder infections, or worse, you're really uncomfortable because you're not emptying your bladder all the way. And some of those patients, actually, it comes down to the nerves. And that's why these kind of nerve therapies can help all three of these, because when it comes down to the nerve, we can intervene at the level of the nerve. So let's go through each of those kind of separately. So what's a normal bladder? The normal bladder needs to store the urine. So a lot of people are on blood pressure medications that have a diuretic effect or a water pill. And they say, oh, well, I don't want to do anything about my incontinence because I don't want to reverse the effect of the water pill. So remember that those kind of treatments work at the levels of the kidneys, and they make you make more pee that your bladder then collects. So nothing I'm going to do is going to put you at risk for not responding to that water pill or the blood pressure pill. What we are trying to do is help that bladder do its job of storing the urine comfortably. And then when you want to pee, what is supposed to happen is that your bladder is supposed to send a signal back up to the brain and say, hey, we're getting pretty full down here. Can we go ahead and pee? And you're supposed to be able to say, no, I'm in line at the grocery store, cannot pee right now, wait it out. And you're supposed to be able to suppress that. And what can happen in overactive bladder is that the bladder just starts to override that signaling. It doesn't even stop to check in. It doesn't listen to you saying, not right now, I'm in line. It just goes right for it. And that's more of the overactive bladder. The normal bladder is supposed to be able to wait until you're on the toilet and say, okay, now I'm ready. And then the bladder muscle contracts here. The muscles at the base of the bladder relax and your pelvic floor relaxes so that you can pee and get all the way empty. If you come and see me, you're going to hear some tidbits about bad habits. And one of my pet peeves is people that hover over the toilet, because when we hover, because we don't want to sit on the toilet, we're squeezing those muscles that we're supposed to try to relax so that we can get all the pee out. So a normal bladder function, let the bladder do the work. You're not supposed to power pee and squeeze it out. You're supposed to just relax, sit down, let the bladder do the work of squeezing that pee out, and relax your bottom, relax the pelvic floor muscles so that the pee can actually exit the urethra. So more tidbits like that to come if you come see me. So overactive bladder, this can come in many forms. Some people are urinating frequently. The number to it is 8 or more times a day. And when you come and see me, try to think ahead of like, how many times am I actually peeing a day, or how many hours can I go between pees? What's normal? Most people, what we're trying to aim for is to go like 2 to 4 hours between pees. That's more of a normal bladder cycle. I actually also pick on people that are like in healthcare or teachers or nurses, any kind of service job really, where you hold your pee too long. That's also a problem, because if we are holding our pee too long, we're stretching out our bladder, and that is going to have some effects down the line of making the bladder more prone to misbehavior or weaker. So normal peeing should be every 2 to 4 hours. You should not go an entire shift without peeing. That's not normal, and it's not good for you. My public service announcement for the day. You should be peeing every 2 to 4 hours. And if you're going more than that, that's actually abnormal. If you're feeling that sudden urinary urgency and you cannot ignore it, you can't tell that bladder to calm down, that's abnormal as well. You should be able to have that ability to repress the bladder. And then urge incontinence, it's slipping out. You feel that urge to pee, and you're going to pee before you get there. That's that overactive bladder type of incontinence. And nighttime's a little tough. So nighttime is always, I feel like I'm always disappointing people when I talk about this. So it is normal to get up and wake up to pee up to 2 times at night after age 50, which I hate telling people, because they're like, I want to go back to sleeping all night long. And I think me too, but it's normal. We start making more of our pee at night. So we do get up more, and that's normal. You can minimize that by trying to reduce how the amount of fluid you're drinking after 7 o'clock. So trying to just really drink up until dinner and then stop. And there's some other tricks depending on what kind of comorbidities you have to try to minimize. But the nighttime peeing up to 2 times at night is considered normal. Beyond that, then maybe we might have some bladder treatment I can offer to hopefully alleviate some of that. But I'm going to be upfront with you that nighttime peeing is a really difficult one, and it's sometimes more complicated than the bladder. And we'll get into it more if you come and chat with me. Let's talk about actually, I'm going to come back to that slide. Let's talk about normal bowel function. So normal bowel function, we all have a different pace of our bowel. So what I like to tell people is that not everyone's going to be an everyday bowel movement type of gal. It's just not. Some people are going to be, every other day, a couple times a week, and that could be normal for you. So I want you to think more about, ask yourself what your consistency of the stool is. Is it soft and peanut butter like? That's kind of that's what we're aiming for. Is it all liquidy? Then we probably need to bulk up that stool and try to intervene at the pace of the bowel. Maybe it's too fast. Is it hard little rabbit pellets? That's actually constipated. If it's hard little rabbit pellets, that's too hard. So we want to be that Goldilocks just right, where it's nice, smooth peanut butter kind of bowel movement, not little rabbit pellets, not liquid. I do a lot of counseling on the treatments for that: fiber supplements, probiotics, avoiding foods that trigger us and set us off. But there, at the base of this, there is a different pace that people have. And so not everyone is going to have a bowel movement every day. What I can intervene on the nerve side is how that rectum handles that sensation. So what should be able to happen is that as your rectum fills with stool, you again should have that conversation that your nerves are having between your brain and your rectum to say, hey, we're getting kind of full. Can we head to a bathroom? And again, you should be able to squeeze those muscles and tell, no, I'm not a good time. I'm not ready, and be able to suppress it and come back to it later. And then when you are ready to have a bowel movement, again, you want to be able to get on the commode and actually sit all the way down, no squatting, and relax those pelvic floor muscles and be able to just have the rectum do the work of pushing out the stool. So they're very similar in the way they work between bladder and rectum, and the nerves work very similarly, and they're shared nerves. So what happens when this goes awry? The patients can start developing a fecal urgency, like they cannot ignore, they better be close to a bathroom or it's about to be an accident, or they feel like they might come close, a near miss, if you will. And so you can have fecal incontinence that happens with that urgency. And then we talked about that passive fecal incontinence. So people can have fecal smearing or just a large volume loss without any awareness. And that's very disturbing. It's awful to have that loss of control of your body like that. And I'm very grateful that we have this kind of technology that can actually make a big difference for people. There are treatments that really can help regain control. And so let's talk about like how you're going to work through that. So the first thing is to find a doctor that you're willing to talk to about it. Urogynecologists, not to toot my own horn, but urogynecologists are perfect matches to talk about all this stuff. I love my field because we get to kind of dive in right when we get to know each other. Just right away, we kind of cover all the most embarrassing topics you can think of. And we're going to make it fun. We're going to not make you, it's going to be good. We're going to cover things and feel comfortable with each other. We'll laugh about things but I encourage you to just find someone that you trust, that you can share all this with, because all these things are related. And if you're not bringing it up, I can't help you. And I try to pull it out of you, because I'm also, we have you fill out a questionnaire that's very detailed to have you kind of think ahead of time of like, oh yeah, I do pee every 30 minutes. That is weird, isn't it? And to try to get all that details out. But we're going to jump right in, and if you can't talk about it with me, who can you talk to about it? Let's try to cover as much as we can and make sure we bring this up so we can tackle it. Initial treatment may be something more conservative, maybe changing the way we eat or what we drink. We're going to jump into that next. A lot of times if you can't quite recall, or if we're planning an intervention, we may have you do a baseline diary. So I call that my homework of your visit. So my homework is for you to actually write down every time that you pee, every time that you leak, what were you drinking, and how many pads a day are you changing? So we can really quantify that and make sure that we are getting improvements. And same thing with your bowels. And sometimes tracking those symptoms really helps us recognize, like, wait a second, this is always happening when I eat out or when I have this type of food. And that really helps us figure out what other interventions we can do. And then there are treatments that are just medications and treatments that are beyond that. And so we'll kind of walk you through that whole pathway. So I wish I'd done each of these slides separately because I have so much to say about each of these, but I'm going to try to break it down. Let's start in the overactive bladder section. So, overactive bladder, remember that's urgency, frequency, and peeing more than every 2 hours and leaking on the way to the toilet. That's overactive bladder. The first thing I'm going to pick on you about is I want you to tell me the truth about what you're drinking and how much of it. So what are our goals for fluid intake? As women, we should be drinking 48 to 68 ounces of water a day for our health, for our bowels, to prevent UTIs, to prevent kidney stones, to keep our kidneys healthy, for our skin, all the things, all the important things. So you're actually not helping yourself when you dehydrate yourself to try to not have to pee, because then your urine just becomes more concentrated and it actually irritates your bladder more. So you're not helping yourself by not drinking enough water. 48 to 68 ounces is like 3 to 4 regular size bottles of water a day. And if you're not a water drinker, I'm fine with you doing the flavoring, the packets, I like the new Circle drink that has it has different flavoring that will last you like several different refills. Whatever you can do to trick yourself, but hydrating drinks is key. The thing I'm going to pick on you about is how many coffee, sodas, teas, caffeine, alcohol drinks are you having a day? Because all of those fun drinks are also a diuretic effect. They make you make more pee. They also are irritating to the bladder. They're going to make more of those bladder spasms happen. So we really do have to recognize that is going to be a problem, and it's not going to help you make any headway with controlling your bladder. And I'm not going to make you give up the coffee, because I can't give up the coffee and I need it. And I know you need it, and that's okay. But we got to keep it down to a minimum. You got to meet me halfway of, let's say 2 cups a day of regular size cups, not the like super big ones, like an 8-ounce cup, of your pick, coffee or soda or tea, 2 cups a day total. If you can do that, you'll see an improvement in your bladder, and we can work with that. If your bladder still can't handle 2 cups a day, we can work with that. So we're going to go through some of that. And that's really important to be honest with yourself and honest with me about what we can do on the lifestyle time. There's also something called bladder training, which people always hate that, because they're like, are you telling me I need to potty train myself? I'm like, yeah, I'm basically somewhat adult potty training. So we get in bad habits, and that peeing in every bathroom you see, or knowing everywhere where the bathrooms are, those can be bad habits, where now we're feeding into that urgency with the bladder, and the bladder is deciding just take it and run with it. It gets used to peeing every 30 minutes. It gets used to peeing at every bathroom you see, and it wants to do that. So I will bring you through bladder training exercises, like when you feel that urge and you just went 20 minutes ago and you really shouldn't need to go again. I want you to fight back and be mind over bladder, where you try to suppress that urge, do deep breathing exercises, distract your brain, use those Kegel muscles that you've worked so hard on, and use them for quick flicks, where we squeeze for 2 seconds, relax, squeeze for 2 seconds. And they're just quick squeezes around the urethra. That talks back to the bladder and says, the door is closed. We are not peeing right now. Settle down. All of these things are good lifelong habits that are going to help you keep control of the bladder. And I do want you to try that. It's not a waste of time. It will help you get better control of the bladder. And I think doing that from the very beginning is gonna be very helpful. And pelvic floor physical therapists are another group that can really help you do that really well. Beyond the bladder training and lifestyle modifications are typically prescription medications. And the prescription medications, there are several that are really well tolerated. The downside is the cost. If your insurance doesn't pay well for them, it's like I have to jump through these hoops for you and go through prior auths, and it's just a game of patience and trying to get the insurance to cover the ones that have the least amount of side effects. But these are medications that you take every day, and some people would prefer not to take a medication every day. There are anticholinergics are one group of medication that in particular can have a high dropout rate, probably what's up here like 80%. And I don't know if it's quite that high, but I will say that about that 20% of people having a side effect is a real number, and that is dry eyes, dry mouth, constipation. And unfortunately, there are medications out there that, in my opinion, should just be off the market. And those are things like oxytrol, oxybutynin, detrol, totaridine, detrol. These medications are as old as they come. There's been years of data out there saying that these medications cross the blood-brain barrier and increase our risk for dementia. So why are they still on the market? I don't know. If you're on this medication, please let's change it. There are several medications in that same category that are safer for your brain health, that have been developed specifically not to cross the blood-brain barrier. And if you come to me on an oxybutynin, I'm immediately going to say, can we please come off of that? I just don't think it's worth it. It's not worth it to have any brain fog any more than we're already at risk for with menopause and all that. So absolutely, there are safe medication options that we can work through and find something that's affordable and reasonable and doesn't give you side effects. Great, then we will do that. But there are certainly groups of people that just we can't find a reasonable option. And that's when these third line therapies really come into play. The nerve stimulation therapies or Botox for the bladder. So we're going to get into that in a minute. Let's talk about retention. So I briefly talked about that the bladder can have issues over time where we're not emptying the bladder all the way. And unfortunately, I see a lot of people that were bad habits where they didn't pee all shift long, and now their bladder is very large and weak and it doesn't get all the pee out. So attention for my nurses and my teachers and my service people that no job is worth your bladder. So please, please, please just make sure you're peeing at regular intervals. You shouldn't have to sacrifice your body for your job. No longer than 4 hours during the day, that's what's normal. And if we realize that early, that you're maybe not emptying all the way, but you're not having complications from it, that's the first thing I'm going to tell you to do. Okay, let's time it out by the clock. Every 4 hours, just go and pee during the day to make sure you empty all the way. I'm going to tell you to double void, pee twice in a row, and really take your time on the bathroom so that you can try to get all the way empty. Occasionally I'll try a medication for not emptying the bladder all the way. There's a medication called Flomax or tamsulosin. It's actually more helpful for men than women because it works at the prostate for men. For women, it helps at our bladder neck, which is usually not the problem, but decreasing that resistance a little bit can sometimes help you empty a little bit better. So we can try it, doesn't always work. When it comes to retention, and if it's a real problem where you're not emptying, you're really uncomfortable, or you're getting UTIs, etc., then the mainstay of therapy is to use a catheter to empty your bladder out, which absolutely no one wants me to tell them that. And they're not happy about it, but a lot of women, when they actually start doing it, actually find that they have so much more freedom because they emptied their bladder all the way. And they're not coming back 15 minutes later to pee a second time because they are actually getting all the way empty. And so they now have 4 hours where they don't have to pee again. And so they actually start feeling a lot more freedom from that. Sacral neuromodulation or the nerve therapy is actually one of the only therapies that can help restore that function. So that's a game changer for women that it works for and helpful for. And then we talked about fecal incontinence. Fecal incontinence is another thing that can happen at the level of the nerves, but we're also going to go through, do you have strong pelvic floor strength? That same Kegel muscle wraps around the rectum. So having that strong pelvic floor strength is very helpful. I'm going to have you think about your dietary triggers. Is it a certain food you eat? Is it fatty food? Is it sugary food? Are we doing too many of the fake sugars that have a sorbitol in it? That gives you more diarrhea and fecal urgency. If you've had your gallbladder removed, the way you digest food may have changed with that. Because with the gallbladder is supposed to squeeze out a little bile when you eat something fatty to help you digest it. And when you don't have the gallbladder, the liver just dumps the bile when you eat something fatty. And then that bile dump is like a laxative and it goes right through you. So there are medications for fecal incontinence that are aimed at those patients, at helping those patients basically capture that bile, that extra bile. It's called a bile acid sequestrant that helps you capture that bile and keep you from having that laxative effect. It is an answer to also for people that cannot find a trigger and it just happens and they'll take like a Imodium, an antidiarrheal over the counter. That's an option. I don't love that option because then you're living on Imodium, and is that a way to live? But if it's the only thing that works, that is a legitimate option for you to try. When it comes to fecal incontinence, sacral neuromodulation is actually the most effective therapy we have. For some of us that have had injuries to our sphincter during giving birth to children, having a tear of that sphincter, there are people that are eligible for a sphincter repair. But unfortunately, we've seen in the long term that those sphincter muscle repairs don't stay, they don't help as long as they should. And typically in about 5 years, the symptoms are back. So sacral neuromodulation has really taken over as the mainstay of treatment for fecal incontinence. It is 90% of people respond to the sacral neuromodulation because if you work at the nerves, you can help that rectum tolerate the filling better. So it's a really effective therapy for a very disturbing condition. Going back to overactive bladder, there are 3 beyond sacral neuromodulation. So overactive bladder, we actually have a nerve in our foot that we can treat for overactive bladder. My nurse practitioner, Abby, told me today that she tells patients that you have the highway to the nerves of the bladder and the country road. And the highway is our sacral neuromodulation, our sacral stimulation that I've been mentioning. The country road is down at that peripheral nerve or down at the ankle. And these nerves connect at our sacrum. So you can actually stimulate a nerve in your ankle once a week for 12 weeks and get better control of your bladder, which is mind-blowing to most people, but this is the least invasive therapy I have to offer. We do it with a little acupuncture needle, a little TENS unit, and you stimulate at the foot and sit there. It doesn't hurt. Done it to myself, feels like a little tingling, and that helps control your bladder. The main thing is this is time consuming, and there are companies and devices coming out to help stimulate at underneath the skin, like put an implant there, and that may be a good option for some people. There is bladder Botox. Botox, I think, is a great option for people that are comfortable with it. Some people just feel like their Botox is something that they're more comfortable with the idea. Botox, it's the same Botox that we're putting in our faces to smooth out the wrinkles and all that. So it's very helpful in preventing those bladder spasms. But it's a toxin that is placed into the bladder muscle, and that helps prevent those nerves from firing. It unfortunately does have to get repeated, though. This is not a one and done. This is every 3 to 6 months. So you are coming to see me, for 2 to 4 times a year to get your bladder Botox. The main risk of why people stop Botox is they either just get tired of the repeat procedures, or if you're getting more bladder infections with Botox, it's likely not a good idea to continue to do an in-bladder treatment for your incontinence, or if you're having trouble peeing. So just like Botox can kind of freeze your face and keep you from being able to lift your eyebrows or make expressions, in the Botox version in the bladder is that you have a hard time emptying the bladder out. It's too strong for your bladder, if you will. And if that happens, then at the worst case scenario, you'd have to catheterize yourself for a little while until that Botox wears off. Or we're able to make do and let it wear off. but that's one of the feared side effects of Botox. And then one of my favorites is the sacral neuromodulation therapy. So again, that's helpful for urge incontinence, urinary retention, and fecal incontinence. If we stimulate that sacral nerve with a little lead, it's like a pacemaker, at the nerve, we can help restore the function of the bladder and of the rectum. We trial this one in the office first. So one of the reasons I do like doing this therapy is because patients actually get to try it out before you buy it, if you will, or before you actually have it implanted. It's going to restore that communication between the brain and the bladder. This is very similar technology to pacemaker technology, of the pacing of your heart to keep your heart at a regular rhythm. It's keeping those sacral nerves at a regular rhythm. And it's always on. You don't have to mess with it. You don't have to be messing with it, turning it on and off. The battery is constantly running, and the lead is constantly stimulating that nerve to normalize its activity. This is one that's very common. If you start talking to people about it, I bet you'll find someone that already has this therapy. It's in Axonics is one of the companies that does sacral neuromodulation. It's a restorative therapy. It restores the normal control of the bladder and the bowel. And can help with all three of these conditions. So it's a rare therapy that if you have both overactive bladder and fecal incontinence, this is a perfect option for you. Or if you have both overactive bladder and you don't empty your bladder well, which I see a lot in my teachers and nurses and people that don't pee enough, then this is a perfect therapy for you. So there are certain people that I'm like, oh, I think you should head towards this one. This is really helpful if you have a combination. And how does it work? It's really about restoring that normal communication, helping those nerves not over respond and overreact to a little bit of pee in there, or same with the bowel. The thing I like about this a lot is there aren't many things in medicine where I can say, well, why don't you try it out and see if you like it? There's actually a trial run, and it's for me and you to make sure that we feel good about the therapy and that this is a good answer for you. But it's also a requirement for your insurance company. And the reason is that they want to make sure that before you have this implanted, that you are going to be a good responder and that you're happy with the therapy. So it does take a little bit of homework. I do want you to do a diary for me and make sure you're recording everything about peeing and leaking, and same with the bowels. And then you come into the office and I just numb up the skin over your tailbone area. And we put a temporary wires through the tailbone right next to those nerves that go to the bladder and the bowel. And then I tape a temporary battery to your back. And you wear that around for a long weekend for me. And during that long weekend, we're going to keep that dressing dry. We're going to not do too much lifting or exercise. And then other than that, I want you to live your normal life and see, am I able to hold it longer? Am I not leaking? You're actually going to record the symptoms and prove it to yourself and to me and to your insurance company, so we can get it covered, that this is worth it. This is worth it for you. And then once you do that test and prove it, then we go on to have an outpatient, minimally invasive procedure where we put you under a light anesthesia, and I place that lead next to the nerve with X-ray, and then put a battery in place. And that battery does not stick out. It's underneath the skin. I put it underneath the panty line so we can still wear our bikinis without anybody knowing. And it's a battery that, depending on what version you get, whether you get the one that you recharge a couple times a year, and that gets 20 years on average out of it, or if you get the one that doesn't recharge, and that's a 15 plus year. How long the batteries last also depend on what you're running the device at. So if you're running it at a higher amount, it's gonna go through the battery faster. But that's 15 and 20 years is the average, which is huge. I mean, that's a long time to be able to just set it and forget it. And a lot of people get to that point where they're just able to have their program on that's constantly stimulating the bladder, and then they feel normal and they come in, at least yearly for me to check on them. And then for people that it's not as straightforward and they still have some issues to work through, we work with you and we'll come in and have you come in and help you figure out what pattern of stimulation your nerve likes, basically. So the rechargeable device, I think it's great for smaller folks that don't have as the muffin top that a lot of us have. That's a good option. And the other one, the F15 is a little bit bigger, but still easily hidden. It doesn't stick out at all. And this remote is a highlight of this therapy, is that it's easy to use. There's nothing to recharge. So there's nothing, if you get the recharge free, it's everything 100% is recharge free. And people always ask about MRI. And yes, nowadays, all of this therapy is MRI compatible. Woo, so you don't have to think about that. We just have to make sure I show you how to turn it on MRI mode, and we can help you through that. Clinically significant improvement is 93%. It is a very effective therapy. So this is most patients are satisfied and would recommend a friend. So overall, this is one of our ways to get back to a normal life, and certainly one that I love to do. But I'm here to meet you exactly where you're at and whatever you're ready for. And we have all of those options available, as simple as it comes to me teasing you about your soda addiction, and to these fancy devices. So we have a couple minutes here. If there's a few questions, we can answer.
Amazing. Thank you so much, Dr. Reub, for walking us through this informative presentation. Awesome. You had me cracking up, but also I learned a lot too. So appreciate you. We do have some questions. Before we transition to the questions, I am going to launch a quick poll. It is just 3 quick questions. It will help us to learn more and to get better for the future. So hopefully that poll is showing up for you. And we do have some questions in the chat. If you'd like your questions answered, please go ahead and put those in the Q&A feature located at the bottom of your screen. And the first question we have is it possible to have overactive bladder and stress incontinence at the same time?
Yeah, it definitely is. And I like to make that distinction of there are two, you can have both. Let's tackle the one that's most bothersome. But if you do have both, realize that those are 2 different treatment plans, treatment paths, and so that you may need multiple treatments to really meet your goals.
Second question is, can you please explain what you meant when you said double P in the presentation?
So the double P. So when the bladder is getting weaker, sometimes it doesn't get all the way squeezed down to its best on your first go. And so if your bladder is getting weaker, it's better to give your bladder 2 opportunities to pee. So what I tell women to do is sit all the way down on the toilet, relax your muscles, and let the bladder squeeze happen. And then actually wait there for a minute and then see if you can get a second pee going. And that second pee will help you get all the way empty if your bladder wasn't strong enough to do it in one.
And where are the procedures usually done?
Yeah, these are the type of procedures that are done typically in an outpatient surgery center, like an ambulatory surgery center. Some of these procedures we do in the office, but it's a variation in the under local anesthesia or with a like minimal sedation type of treatment.
And along that note, is there anesthesia or stitches with the trial procedure?
That the trial actually is just the temporary wires, and then I tape a temporary battery, a little fanny pack, if you will, to your back, and you wear it around for a couple of days. But it's only that one time, I promise. So but no stitches for that one, just those wires.
And is the trial painful?
So we use lidocaine so that we can numb up the skin. And for the trial, I actually want you to tell me where you feel it. So, so I do need you to tell me about it, and I just try to make you as comfortable as I can with the lidocaine and really taking our time.
So I'm currently taking OAB medication. Is this something that I'll have to take my whole life?
So, I mean, the realistic answer is it's possible. Some patients are going to be taking overactive bladder medications lifelong. There are some patients that have had enough success in the conservative treatments, that managing our fluids, the bladder retraining, and are able to come off their medications. But if you've done all that and you still feel like you're needing the medication, and you just don't want to take a medication anymore, that's also where we can still consider those third line therapies. Because if the hope is that we would be able to get you onto with a Botox or the nerve stimulation therapies instead of long-term medications.
And is this procedure covered by insurance?
So everything I described today is covered by insurance. These are not experimental. These are therapies that have been on the market for 10, 20 years, and we can absolutely get it covered by insurance. We just have to go through those steps we talked about of making sure we're doing the conservative things first, trialing medication if that's the treatment algorithm, and then we can get those other procedures covered by insurance too.
Is there a best medication for OAB?
Ooh, I'm gonna get in trouble. I would say I like beta-3 agonist, and the newest medication on the market is Gemtesa, and that one is the most specific to the bladder with the least amount of side effects and medication interactions. Now, some insurance companies are coming around to realizing that's the safest medication and making that a first step and having good coverage. But it's taken a long time, and I'm right there with you of how frustrating it is to have what I think is a better medication for my patient and what I think is safer for myself and things like that, and still not able to have the insurance company get on board with us. So it's a process, and I'm very used to playing that game, and I will do it together.
Understood. So I'm experiencing both incontinence and prolapse. Do you provide treatments that address both issues?
Yes, so they can be related to each other. Sometimes it's all about function. Sometimes the anatomy is also affecting our function. And so absolutely part of that conversation that we jump into when you first meet me is, well, let's take a look at your support. Let's look at the anatomy and see if there's any intervention I can do on that level that could get you a better quality of life. So absolutely, we will kind of do it all in a first visit. That first visit is a lot, but then we repeat things and go back to it several times because it's a lot to take in.
Okay. And this is the last question. Is there an age limit to getting these procedures?
Absolutely not. We have a full variety of patients, people that have never had a baby and have trouble with their bladder, and that are, young people that have had this since they were, 8 years old and younger. And then patients that had, the more mature generations of life and have been through a lot. Their pelvis has been through a lot. And all of these patients still have options for them. And so I don't want any woman to just settle with diapers. There's options for all of us, and we'll find what you're most comfortable with and start there.
Understood. And we did have someone asking about getting a copy of the presentation, and we'll actually send that out to everyone who registered and everyone who attended as well. And we did have one more pop up. How do you know if axonics or sacral neuromodulation is better for fecal incontinence?
Yeah, when it comes to fecal incontinence, we're going to talk through that a lot of the dietary and your risk factors, like gallbladder, if you've got your gallbladder removed, like I mentioned, and what the consistency of the stool is first. And if you've done the conservative things and really worked at that, done your fiber supplements, done your probiotics, monitored your dietary triggers, and you're not getting anywhere, for fecal incontinence specifically, sacral neuromodulation is actually the most reliable therapy. So we'll work through that together. And if we're not seeing any other simple conservative thing you can do, that is absolutely an option for you.
And this brings us to the conclusion of our webinar. We thank you so much for your time. We ran a little bit over, but is there any final thoughts you'd like to share with us before we go?
No, absolutely. Thank you guys so much for joining me. I love talking about this, and I'm so excited to have so many people, interested in hearing about it and learning more. And if you need any help with this, please come and see me. I'm so happy to help tackle this with you.
Thank you so much again for your time. Thank you, everyone, for attending, and I hope you all have a great evening. Bye.